Welcome to this explainer, everyone. I'm honestly so excited to guide you through this today because I consider this a true high-yield board review masterclass on astigmatism. We're going to connect the raw, optical math of refractions to real-world, high-stakes surgical decision-making. If you've ever felt like astigmatism rules were just an arbitrary list of facts to blindly memorize for the OCAPs, well, we're going to fix that right now. We are teaching for true, long-term clinical mastery here, so you never have to blindly guess on these questions again. So let's dive right in. Here is our roadmap for today. First, decoding astigmatism types, then O-CAPE rapid-fire refractions, the optic communication gap, with the rule astigmatism, against the rule astigmatism, and finally, clinical pearls and pitfalls. All right, starting off with Section 1, decoding astigmatism types, the foundation. So the core question I really want you to think about is this. Can you determine exactly what type of astigmatism a patient has, whether it's simple myopic, compound hyperopic, mixed, just by glancing at their refraction? The answer is an emphatic yes. And listen, you do not need to draw out those complex optical crosses to do it. There is a totally foolproof two-step algorithmic method to diagnose the astigmatism type. It just relies on understanding what the numbers actually mean for where the light is focusing. Step 1. You simply express the refraction in both plus cylinder and minus cylinder formats. Just do the transposition. Step 2. Look at the sign, positive or negative, of the sphere component in both of those formats. Put together, these two signs are going to give you the exact diagnosis. Now, what's really cool here is how beautifully logical this mapping is when you think about it. Think about the physiology for a second. If both sphere signs are minus, it means both principal focal lines are falling in front of the retina, right? That is compound myopic astigmatism. If one's minus and one's plano, or zero, one line is in front of the retina and the other is sitting exactly on it. Simple myopic. If you get a plus and a minus, while one focal line is behind the retina and one's in front, that's mixed astigmatism. And finally, if both are plus, both lines are behind the retina, meaning compound hyperopic. Don't just rote memorize this table, visualize where those focal lines are landing based on those signs. It's a total game changer. Let's move to Section 2, OKA-PRA rapid-fire refractions, active recall. Okay, it is time to put these rules to the test. I'm going to give you a refraction, and I want you to mentally transpose it and diagnose the astigmatism type before I give you the answer. Ready? Here's your first one. A patient walks into your clinic with a prescription of plus 3.0, minus 2.0 at axis 080. What type of astigmatism is this? Take a mental beat here, calculate it in your head. All right, let's walk through the clinical reasoning together. So you're given a minus cylinder refraction. Step 1, convert it to plus cylinder. You add the sphere and cylinder to get the new sphere. Plus 3 and minus 2 gives us a plus 1.0 sphere. Flip the cylinder sign to plus 2.0. Then rotate the axis 90 degrees to get 170. So our transposition is plus 1.0 plus 2.0 at 170. Now, step 2, look at the sphere signs in both formats. We have a plus 3.0 and a plus 1.0. Plus and plus. This means both focal lines are behind a retina. Boom. Diagnosis, compound hyperopia. Let's try another one, maybe a bit more extreme this time. What type of astigmatism is minus 5.0 plus 9.0 at axis 090? Go ahead and apply that two-step rule right now. Okay, this time, we were handed a plus cylinder refraction. Let's transpose it to minus cylinder. Add the minus 5 and plus 9 to get a new sphere of plus 4.0. Change the cylinder to minus 9.0. Rotate the axis 90 degrees to 180. Now look at your two spheres. We started with minus 5.0, and our transposed sphere is plus 4.0. We have a minus and a plus. Differing sphere signs always, and I mean literally always, point to mixed astigmatism. One focal line is in the vitreous and one is theoretically behind the eye. All right, let's do one final rapid-fire challenge to lock this in. What type of astigmatism is minus 2.5 plus 1.5 at axis 128? Visualize that transposition one last time. So we start in plus cylinder. Transpose by adding minus 2.5 and plus 1.5 to get a new sphere of minus 1.0. The cylinder simply becomes minus 1.5. Add or subtract 90 to the axis. In this case, let's just subtract 90 from 128, which gives us 038. Look at our two sphere signs, minus 2.5 and minus 1.0. Minus and minus. That gives us compound myopia. Excellent job if you nailed that. Seriously, mastering this simple algorithm is an incredibly easy way to bank points on your written boards. Up next, Section 3, the optic communication gap, MDs versus ODs. Now, let's transition from the raw optics to actual clinical relevance. You might be wondering, why do we even need terms like with the rule and against the rule? Well, it stems from a pretty fundamental difference in how different eye care professionals operate. As ophthalmologists, we usually refract in plus cylinder because, frankly, it's just easier for the refractionist to push plus during the exam. But optometrists often refract in minus cylinder, and opticians absolutely think and grind glasses in minus cylinder. So consider this trap. If an MD tells an OD, hey, this patient has a lot of cylinder at axis 180, the MD is imagining plus cylinder, but the OD is imagining minus cylinder. They literally have completely opposite impressions of the patient's steepest corneal meridian. Let's clear that up in Section 4 with the rule Astigmatism, or WTR. To solve this massive communication breakdown, we use the historical but incredibly essential anatomical terms. Let's start with the rule Astigmatism, which is named that simply because it's by far the most common type. I want you to build this visual memory trick right now. Imagine the cornea is shaped like an American football lying flat on the ground. The vertical curve is much steeper than the horizontal curve. This flat football is your mental model for with the rule. If you use these terms, it puts absolutely everyone on the exact same page, regardless of what cylinder format they prefer to use. So let's break down the optical physiology of that flat football. Because the vertical meridian, the 90-degree meridian, is steeper, it naturally has more plus refractive power. Now, here is a classic board trap, so pay attention. Do not confuse the meridian of power with the axis of correction. To correct that steep 90-degree meridian, we need to add plus cylinder power along the flat horizontal meridian, which is the 180 meridian, often written as axis 090. Or, if you're an optician, you correct it by taking away power using minus cylinder at the 90-degree meridian, which is axis 180. Oh, and remember, it doesn't have to be exactly 90 or 180. An allowable variance of plus or minus up to 20 degrees still totally counts as with the rule. Moving right along to Section 5, Against the Rule Astigmatism, or ATR. Now, let's see how this builds our understanding of its clinical counterpart. Notice the stark visual difference here. Our mental model has completely flipped. The football is now standing vertically, perfectly balanced on a kicking tee. This represents a cornea, where the horizontal meridian is now the steepest part. Because the horizontal meridian, the 180 meridian, is steep, it carries more plus power. This 90-degree shift completely flips our entire correction strategy. To flatten this out optically, we correct it with plus cylinder power vertically at the 90 meridian, which is axis 180, or alternatively, with minus cylinder power horizontally at the 180 meridian, axis 090. Once again, we're linking the physical anatomy of that vertical football directly back to the optics of your refraction. And that brings us to Section 6, Clinical Pearls and Pitfalls. Okay, let's bring all these concepts together for some high-yield board prep, because this is where we separate the novices from the masters. Why is with the rule of astigmatism so incredibly common in young people? Well, it all comes down to the tight eyelids hypothesis. Normal anatomy tells us that young patients have excellent, snappy eyelid tone. These tight eyelids literally press down on the upper cornea and press up on the lower cornea, steepening that vertical meridian over time. This is a beautiful way to connect basic periocular anatomy straight to the optical findings of the flat football we just mastered. And this brilliant biological progression is a classic OK-up pearl. As patients age from their youth into their elderly years, they undergo structural changes. They naturally develop eyelid laxity. That vertical pressure is released and the corneal shape relaxes and shifts. Because of this, with the rule is far more common in the young, but against the rule becomes the dominant pattern in the elderly. But what if you see the exact opposite? What if you see an elderly person with the rule, or far more dangerously, a young person with against the rule? I want you to memorize this quote. Some refractive surgeons will outright refuse to operate on a young person with corneal against the rule astigmatism. Why? Because you must consider it prima facie evidence of corneal ectasia, like keratoconus, until proven otherwise. This is a massive clinical red flag, folks, and a highly testable board trap. A simple refraction can warn you of devastating surgical complications if you just know how to read the anatomy behind the numbers. Let's conclude by synthesizing this entire explainer into one final, highly realistic patient case. A 22-year-old presents to your clinic requesting LASIK. The refraction is plus 1.0, minus 4.0 at axis 80. First, you transpose it. Minus 3.0 plus 4.0 at 170. A minus and a plus sphere means it's mixed astigmatism. Second, look at the cylinder. They require minus cylinder at axis 80, that's near 90, meaning their horizontal meridian is excessively steep. That is against the rule of astigmatism. So we have a young person with high against the rule of astigmatism. The red flag should be absolutely screaming, suspect keratoconus, suspect ectasia, and that is an absolute contraindication for LASIK. If you can connect those dots, you are truly thinking like a master clinician. But consider this before you go. If this exact same young patient with against the rule astigmatism presented for a routine cataract evaluation instead of LASIK, how would this alter your lens calculations and your surgical incisions? The optics never change, but the surgical stakes absolutely do. Keep applying these rules, visualize the anatomy, and I'll see you in the next explainer.